Thank you, David and Pam, to invite me to talk about your heart, literally. And I believe I know this is a prostate cancer support group. And I guess the aim of the talk today is basically, why is heart important, especially in patients with prostate problems? What to do with yourself if you got any chest heart problems, for example, chest pain. And I guess for all of you, one of the most important things is how to prevent a heart attack. And also, the technology these days are going like a million miles an hour. There are basically new tests to look at your heart, left, right, and center. I'm just going to have a quick overview of all the new investigations that can be done or should be done or whatever. From my point of view, I've done a similar talk at Coronary Council a few months back. I'm quite happy if you got any questions and stop me in the middle of my presentation. I'm more than happy to answer anything, preferably heart-related, because your prostate, I'll struggle a little bit. Purely from a prostate point of view, I think the link between prostate cancer and heart itself is not a lot. But the main thing from prostate symptoms point of view is erectile dysfunction do have a strong connection with heart disease. This is basically a graph to look at the causes of erectile dysfunction, which tend to happen, as we get older. And if you look at it, vascular disease is 30% of the main cause. 40% of the cause is diabetes. And these two things are very important from the heart point of view. So if you purely look at the pie chart, 70% of the cause for erectile dysfunction has something to do with your risk factor for heart disease. And that's why, and if you look at erectile dysfunction, the four major interactions are neuro, vascular, and blood flow, hormonal, and psychological. I'm obviously concentrated on vascular and blood flow because I'm a cardiologist. And however, if you talk to your urologist, purely from erectile dysfunction point of view, the main aim of treatment is also looking at vascular and blood flow. Unfortunately, from neuropsychological point of view, that's actually very hard to treat. However, vascular and blood flow, for example, or the Viagra's and things like that, that's where they concentrate on. If you purely look at the erectile dysfunction, to maintain an erection, which is the main problem, what happens if you don't know about it is basically there's a sudden increase in blood flow into the corpus cavernosum, which is normally there's not much blood in it, but there's a lot of venous plexus in the corpus cavernosum, and when you get some stimuli, then there will be sudden increase in nitric oxide in the body. It will dilate the venous plexus. A lot of blood will rush into the corpus callosum. There will be a sudden obstruction of the venous drainage of the penis, and that's why you get a lot of blood filled up in the corpus callosum, and that's why you get an erection. As you can probably understand, if you've got artery or vein problems, this process will struggle because you're not getting enough blood in. And I think one of the main causes for erectile dysfunction is basically impaired arteries, either via smoking, via diabetes, via all the vascular risk factors, impairing blood flow into the corpus callosum, and that's why you can't get erected. Purely from a cardiology perspective, how is it important? Because I think many years ago someone did a prostate cancer prevention trial. And therefore, I think they enroll about 8,000 patients. Exact number I can't remember, but they compare patients with ED, which is erectile dysfunction, with patients with no erectile dysfunction. And what they found is patients with erectile dysfunction has a much higher vascular risk. Their risk for a heart event is actually quite a bit higher than patients with no erectile dysfunction. If you think about it, that probably makes sense because 70% of erectile dysfunction is caused by vascular problems, if you remember my pie chart. All these vascular problems itself is also a risk factor for heart attack or angina or ischemic heart disease. So understandably, if you have this, then your risk factor for blocked artery increase just because of the fact you have it. And therefore, from a heart point of view, your prostate probably signaling something happening to the arteries, and that's why you probably need to pay more attention to it. And this is what I'm talking about. I'm not going to talk about depression, but purely from prostate and heart disease, you can see obstructed blood flow in the small arteries. And therefore, if you've got an obstructed artery down here, there's every chance that you're increased risk of having an obstructed artery up here. So that's the nature of it. I keep telling patients, if you have one blocked artery in your body, the risk of you having a blocked artery elsewhere in your body increases dramatically. That's just nature. If you have normal arteries everywhere, then your risk of having a blocked artery is much lower. Now, I'm going to concentrate on the heart. That's my prostate bit. I think we all understand that heart disease is a very important aspect of our healthcare. The reason why is I don't think this statement is true anymore. I think cancer actually overtaking it in the last 1 or 2 years. But look, this is one of the major leading causes of mortality in Australia. And 2007, you're looking at 20,000 deaths. Problem for myocardial infarction, which is myocardial infarction is what we call heart attack. Your acute heart attack. The crux of it is actually 50% of people who have had a heart attack don't get to hospital. So they drop somewhere on the street, cannot be resuscitated. By the time someone gets to them, it's already too late. So if you look at the stats, half the people don't get to hospital. So it's something very nasty, and that's why we as a cardiologist try very hard to try to stop it from happening. I mean, that's our job. If you had a myocardial infarction within 1 year, 40% of people do something bad about it, and 25% of heart attack people die within the first hour. So it is something very nasty, and therefore that's why it's so important. And medical term, I just run through it very quickly. We call it AMI, acute myocardial infarction. That's the acute heart attack. What happens is when there's a sudden complete occlusion of a coronary artery causing no blood supply to the heart, if you don't fix it early, this damage is permanent. So the question my patient keep asking me is, okay, heart attack is such a bad thing. Do I get any symptoms before that? Will I get any warning signs? The honest answer is yes and no. If you get a blocked artery, sometimes you get angina. All right. However, one of the main problems for acute heart attack is when quite often your arteries are not that much blocked. Quite often the artery that causes heart attack is only 40% blocked. What tends to happen is that 40% artery is actually quite unstable. They rupture, a clot form in the artery, and they block off the artery acutely. You get a heart attack from that sense. So despite your artery is not 99% blocked, quite often because of the acute rupturing of the artery, you don't get it. That's just a basic overview of the heart. So mainly when you listen to a cardiologist, veins I'm not too fussed about. You don't get much problem with veins. 3 main arteries in the heart. Usually it's the left coronary artery divided into left anterior descending and left circumflex, and the right coronary artery. What happened is what I've been describing before, a sudden occlusion, a rupture of the cholesterol plaque. And quite often these arteries are only about 50% blocked. You rupture it, they bleed into a plaque, then a clot formed, and they cause a sudden acute occlusion of the artery. And that's how you get a heart attack, an acute heart attack. It's different from angina, where you get a chronically blocked, say 80% blocked artery, but stable. Acute heart attack happens when there's a sudden rupture of the plaque. And that's why the two terms are different. When I'm a medical student, I never worked that out. But one is acute, the other one is chronic. And obviously, acute one is nasty. Typical symptoms, basically, we tell patients what to look for, all right? Your typical classical symptoms for acute myocardial infarction is central of the chest. So people think that, the heart is on the left-hand side, so you get left-sided chest pain. Purely from a classical textbook type of view, you get central chest tightness described as pressure. Quite often, they describe it as like an elephant sitting on your chest. The pain quite often radiates to the left arm and also radiates up the neck. And therefore, if you walk into emergency and you tell patients that, you tell the doctors that you are having left arm pain when you walk, we presume you've got a heart problem until proven otherwise. That's part of the classical symptoms. With acute heart attack, you also quite often feel very nauseous and you feel very sweaty. The problem from our point of view is unfortunately just like the rest of life, things are very typical. So therefore, we can't be sure when the chest pain is hard, when the chest pain is not. So we quite often treat chest pain as a myocardial infarction until proven otherwise. So you walk into emergency next door or North Shore or whatever, you've got chest pain, they'll bring you into bed straight away and do an ECG straight away. So we don't muck around with it. The thing I normally get patients to do is if you have chest pain, you're worried about it, just call an ambulance. The reason why is treating chest pain, treating myocardial infarction, timing is everything. And especially if you look at the stats, 50% of a patient with a myocardial infarction don't get to hospital. The reason why is if something bad happens, you need an equipment called defibrillator right next to you to get you out of it. If this happened in the middle of nowhere, then you're pretty much gone. Ambulance are equipped with ECG machine, and urgent treatment can be initiated with the ambulance, and basically to keep you alive. And therefore, quite often the problem for men in general, myself included, is basically we thought, we have chest pain. Let's see how we go in 2 hours' time. Try to sleep through it and go, it's just pain. I'm a bloke. I shouldn't worry about a little bit of pain. The problem is by the time, if you wait for a whole day, you go and see a doctor, by the time management treatments are initiated, quite often it's too late. The damage is irreversible. So this is what my next slide. Timing is actually crucial, AMI. The gold standard of treatment is actually to open up the artery within 6 hours. If we do that, the damage is actually very minimal, if we can do that. Any delay, more minutes delay, after we open up the artery, that causes more death in the heart muscles. You actually get a lot more heart failure. So urgent coronary angiogram has always been the treatment of choice. And basically, you don't want to end up with a patient like this when you had an acute heart attack and the doctor talks to the patient, second count, and start talking to students about it. That's the last thing we do. Matter of fact, if you go to North Shore right now, and also the STENT, if you had an acute heart attack, the North Shore guys are actually really, really good. They're doing something called ATAMI, which is emergency triage acute myocardial infarction. What happened, let's say if you had a heart attack in, say, Manly or whatever, somewhere far away, the ambulance will pick you up. They will do an ECG on you. The ECG looks like a heart attack. The ECG will be faxed to North Shore emergency, seen by a consultant in North Shore. They go, this is a heart attack. What happened is the ambulance will go straight to North Shore. It will go straight to the cath lab. So it wouldn't stop in emergency. It wouldn't stuff around anywhere. It would just go straight up the lift to the cath lab. They do an angiogram straight away. That is world-class service from my point of view, because what they find is you go far through emergency, you go through triage, through emergency doctors. That will normally mean another delay of at least 30 minutes. As I said to you before, every minute count in a heart attack. So the service up in North Shore and lower North Shore at the moment is world class. It is world. They can't do it any quicker than what they're doing right now. So what they normally do, if you've got an acute heart attack, is basically an angiogram. I'm not quite sure if anyone had an angiogram in the audience, but angiogram, it sounds very scary. It's basically a needle either into a groin or the wrist. Traditionally it's through the wrist, through the groin. But these days, there are more and more people doing via the wrist because it's just a little bit cleaner. It is an invasive procedure, but from our point of view, we do it quite often. So it's naturally not that bad. So what we do is we puncture the groin, we feed a plastic tube into the heart arteries, then we shoot some contrast into the artery directly to see if there's any blocked arteries. All right, the whole thing takes about 20, 30 minutes. If we find a blocked artery, obviously, depends on where the blocked arteries are, we can try to feed a stent down. If there's a lot of blocked artery, we might need to do a bypass. But that's the procedure in the crux. I've got a video at the end to show you. So the procedure is actually quite safe. Complication rate there is, so 1 in 1,000 for what we call major complications, including we can actually induce heart attack, we can induce a stroke, and sometimes you do need an urgent bypass operation. But from our point of view, it happens very rarely. There is a bit of minor complications, including bleeding or infection, but it's not normally something I worry too much about. Timing is crucial. The 2 hospitals around you, I guess you all live around this area. Sydney Adventist, which is where we are, North Shore offer 24-hour, 7 days a week service. So the service is great. Not very good for our own health because we do need to wake up at 2 o'clock in the morning and try to fix up heart attacks. Unfortunately, heart attacks take weird times. So the North Shore guys, they're actually the first one who started the 24-hour service in Sydney. Initially, they started with just 2 cardiologists, Greg Nelson and Helia, and I think they hardly slept like 5 years. But that's the service they provide, and frankly, that's a super service. So if you have a heart attack, you come to the SAN, you come to North Shore, you get an angiogram straight away within 20 minutes, and you can't get better than that, to be honest. This is basically just an echocardiogram. The reason why I put them here is basically these are 2 patients all with heart attack. I know you're not trained for these things, but I hope what you try to appreciate, this is what we call the left ventricle, which is the bulk of the heart doing the job. And this is just a patient who came in with an acute heart attack and had an angiogram, open the artery within 30 minutes. My word for it, this is normal function. This is someone who basically had a heart attack but had a delayed angiogram open 2 days later. And also take my word for it, this is barely moving. I hope you appreciate the difference between the 2 hearts. And you got one patient, the first one, your artery got open straight away. Their life was the same afterwards. They had no chest pain, no shortness of breath. The heart function remains normal. They just keep going. The second one, because of delayed presentation for whatever reasons, you go into heart failure. The heart function is barely moving. You get short of breath. You get leg swellings, and your 5-year mortality increased dramatically. You're much more likely to die with this than a normal heart. So I can't stress more enough. If you don't take anything out of this talk, chest pain, we do deal with it seriously. Don't worry about people saying that you're stupid or anything. If you're worried about chest pain, you've got new onset chest pain, bad enough for you to worry about it, call an ambulance. It's the safest thing to do. The coronary angiogram is not available everywhere. So, if you're somewhere in the country or if you, I don't know where, if you're in America, UK, they're actually not available everywhere. Next best option is actually a clot buster, where we inject some medication to open up the arteries. Tend to dissolve clots, and they do quite well. The main problem is they only got a 70% success rate. If you're the 70% lucky people, then you're very lucky. You're no problems. But the problem is when you're 30%, then you're quite stuck. You're 30%, then what happened in New South Wales is then they call a chopper from Bankstown. They come and pick you up, fly you back down to Sydney, and then get an urgent angiogram done. You can imagine this will usually take 6 to 7 hours after the thrombolysis go in. So,
What's your response to, as a first aid procedure, if you were sort of travelling or in an isolated or some distance from help? What is your response to giving the patient, say, I don't know whether it be 1 or 2 Aspro Clear dissolved in water?
I'm more than happy. I think.
Do you think there's any use at all?
Not much. It's better than nothing. I think the thing is, let's say you're somewhere in Northern Territories or something, yep, in the middle of the desert or whatever. You have no medical care within 500 k's, which is quite common. You suddenly get chest pain. The reality is, look, the care is going to be suboptimal no matter what we do, just simply because you're in the middle of nowhere. Chest pain, the main worry is a heart attack. And the heart attack is usually caused by clot forming in the arteries. The standard treatment from our point of view in emergency, in ambulance, is actually to give you a 300 milligrams tablet of Aspro. And I think if that's all you got, that's what you take. All right? And then seek medical attention urgently. But if that's what you got, then I suggest 300 milligrams of aspirin, and then find a hospital, find a doctor somewhere. So if you got stuck in the middle of nowhere, then obviously seek medical attention urgently. It's always quite difficult. In heart attack-wise, the urgent treatment has always been aspirin, 300 milligrams a day, so one big tablet of aspirin. That itself is not going to open up your artery, but what it does is it thin your blood, and hopefully, if your artery is not completely blocked, by thinning your blood up a little bit, you reduce the rate of it blocking off again. But, that is as good as the treatment you can get when you're in the middle of nowhere. So the question is, does Panadol work the same? The answer is no. The reason why aspirin works not because aspirin is a painkiller. What aspirin is an antiplatelet agent. Aspirin thins the blood. When you have a clot, presumed clot in the artery, in the heart artery sitting somewhere, as you can probably imagine, the thinner the blood, the better. All right? Panadol itself is mainly a painkiller. It doesn't have any antiplatelet effect. So just on that, it doesn't work.
In circumstances such as Joan has the question she's just asked,
yep.
If one has the nitrolingual spray available,
yep.
is that of any use whatsoever
in
myocardial infarction?
Not for myocardial infarction, but the problem is it's always very difficult for you or for me, for anyone, just on the phone to know if you're having a myocardial infarction or if you are just having a little bit of an angina attack, all right? If you had a completely occluded artery, in the medical term we call it STEMI, S-T-E-M-I. It's not something you need to know. Completely occluded artery is not going to work. The reason why is nitrolingual spray, what it does is it dilates the arteries, all right? So it opens up the arteries a little bit when you take it. Just imagine, when the artery is completely blocked, it doesn't matter how much you dilate it, it's still completely blocked. However, if your artery, say, is 95% blocked, which is what happened in unstable angina type of problems, you dilate it a little bit, that might help you a little bit. So, if you feel okay, you get a chest pain, I don't mind a little bit of nitrolingual spray. The only problem for nitrolingual spray is it drops blood pressure. So in acute heart attack, in the middle of nowhere, if your blood pressure is a little bit low, you take a nitrolingual spray, that can just get you unconscious. So yes and no. I would probably try it myself, but if you have it available. But really, obviously, you've got a blood pressure machine somewhere to measure it. I'll keep going.
Good. Thank you.
Anyway, the whole crux of thrombolysis is not very good. If you can have an angiogram, you always have an angiogram, in my point of view, because angiogram, you open the artery. The picture is in front of you. Thrombolysis is a little bit of guesswork afterwards, and you still need an angiogram afterwards anyway. But unfortunately, you can't have a cath lab literally everywhere. Even though in Sydney, there is actually more cath lab than actually at the moment. There's about 10 cath labs in Sydney in operation, and another probably, I lost count, about 5 in the country. So we, as a healthcare, is actually doing very, very well. We actually got a lot of cath lab, purely from heart point of view. But you can't expect a cath lab in the middle of Northern Territory, for example. They actually haven't got one in Northern Territory. I think the only one is in Darwin, where they don't put stents in. So it really depends on where you are. Look, that's acute heart attack. I guess one of the main reasons why you're here is how to prevent a heart attack. And that is a very, very big topic. We, as a cardiologist and also GP, basically look at what we call risk factors for ischemic heart disease. And we basically tell you, OK, these are the risk factors. What can we do about it? From my point of view, the most important risk factors, unfortunately, is genetics. It's the one thing that we can't do anything about. The moment. We can't change your genetics. And to be honest, I can't see that changing in the next 20 or 30 years either. The second most important thing is smoking. So smokers have a much higher risk of blocked arteries. Hypertension, then diabetes, high cholesterol is also very important, and obesity. These are the main risk factors for ischemic heart disease. These are the main things I usually talk about and talk to patients about when they come in and see me regarding the heart problems. These are the things I target. There are multiple things where we use and also GP use that can help you. I think in the last few years, there are more and more information and more tools where we can actually what we try to do is to try to quantify the risk for you. For example, rather than I tell you, you might have a heart attack in 10 years' time, we actually give you a number. And the reason why we tend to do that these days is because people seem to respond to numbers a little bit better than just talking. When they see a number in front of them, they start to worry about it, and they actually get their act going. This is one of the things the GP can use. Basically, what they do is they look at your age group. For example, you're 55, then you're 55. Blood pressure is 140, then you go 140, and then you look at the cholesterol HDL level, and then they give you a risk score, a color. So just putting yourself into a table like this, you can probably tell how high risk you are from the heart point of view, and therefore how aggressive or how risky you are and what you should do about it. The other thing, this is another thing that you can actually go on the net to look for. I think it's knowyournumbers.co.nz. These are one of the things that GP use too, where they basically type your age in, they type your cholesterol level in, they type your blood pressure in, and they give you a risk for heart problems. And the interesting thing is, if you do something about it, for example, your diabetes get under control, your cholesterol get under control, your blood pressure starts to come down a little bit, your red line will come down to a green line. So this is actually a very good score in order to help you and help us to know how risky you are. And you can also see what kind of benefit we're talking about by doing all the right things. These are some of the studies, which is very complicated. I think I'm running out of time anyway. So basically look at primary prevention, lifestyle intervention, and lifestyle intervention is as important as any medications we use in order to prevent heart problems. So what kind of lifestyle intervention we're talking about? So if you look at the Heart Foundation, American College of Sport Medicine, they're actually fairly similar. The crux of it is basically we recommend some form of exercise, preferably every day. And the exercise we talk about are not asking you to go to the gym and start bench pressing 150 Ks. To be frank, I don't think I can. So not asking you to run a marathon either. But all we ask for is probably just 30 minutes. I normally go, if you can do 1 hour, it will be great. But at least 30 minutes of what we call moderate intensity. Moderate intensity quite often is just walking up and down the hill a little bit, or even on the treadmill. That's all we ask for. We do not ask for any strenuous exercise. We do not ask for any weight training. But as long as you get yourself moving and get some aerobic exercise in, we are quite happy with. I prefer 7 days a week, 30 to 1 hour. But if you just do 5 days a week, anything is better than nothing. So that's one of the major risk factors for patients. Patients start to get old, they start to get obese, they go, I'm getting too tired, I don't walk, I just sit at home watching TV and take every single tablet under the sun, like CoQ10, etc., etc. That's not good. If you don't move, you're going to get problems. That's the nature of human being. None of our tablet is good enough to replace all of these things, unfortunately. So this is the basis of all prevention of improving health. You can't get away with it. So that's just a simple cartoon. Exercising 1 hour a day or being there 24 hours a day. Weight gain and hypertension. Obesity is a big problem, especially at the younger age group and also older age group. Weight gain is bad in multiple ways. Being obese, you basically increase the risk of hypertension. There are multiple data to suggest that the heavier you are, the higher your blood pressure is. There's a lot of patients who came in and see me and go, my blood pressure is 150 on 80. Can I not take medications? And the answer is yes, but we still need the blood pressure to be lower. And the only thing that's going to lower the blood pressure without medication is actually exercise and weight loss. If you can lose 10 Ks, you will probably lower your systolic blood pressure by 6 to 10 millimeters of mercury. That is actually very good. So had a high BMI. The BMI is the number we use to measure obesity. You are at an increased risk of literally everything, including cancer. And so one of the main things in health is to actually be fit and try to lose weight. Don't be obese. Obesity is no good for you. And also help diabetes. And also a lot of patients ask me about diabetes, how to fight off diabetes. The most effective way to fight off diabetes, in my opinion, is weight loss. It's not insulin. I'm saying that insulin is actually very, very good. But however, you don't want to go that far if you can help it. If you got borderline diabetes, rather than put you on metformin or whatever tablets we give you, I would much prefer to ask you to lose weight. If you lose 10 kilos, your blood sugar will come down. It is a much better way to deal with it than taking long-term medications. So this is what you can do. Unfortunately, this is not something I can do for you. It's up to you, unfortunately. And that's the most important part. Dieting, I'm sure you've seen a lot of TV ads, whatever. From my point of view, it's low salt, low fat diet. You try to avoid red meat. You try to avoid fat. You try to avoid takeaway food. I think this is pretty clear cut. Blood pressure, it is an ongoing problem, especially when we live longer and longer. The thing about blood pressure is you do need to understand that blood pressure increases with age. The older you are, the higher your blood pressure will become. Unfortunately, that's a natural progression of life. What happens is when you get older, your artery gets stiffer. It's just like an old pipe. And if you can imagine an old pipe, it's just harder to pump than a new pipe. And that's why your blood pressure needs to be higher to pump an old pipe, which is what happens in blood pressure. The main problem for this is a high blood pressure. I keep telling patients how you drive a car. If you step on it and you rev till 7,000 reps every day, your engine is going to break down quicker. You wear it down. It's just like a blood pressure. Your blood pressure is sitting at 200. You have to think your heart and kidney will run down a lot quicker. And from our point of view, we want longevity. We want long-term use of the organs, and that's why we recommend a lower blood pressure, despite your blood pressure being 150 at the age of 80. It's probably your natural. It's not a disease or anything. It's basically just you. But having a blood pressure that high is still not good for you long term. We aim for a BP target of a systolic blood pressure of less than 140 and a diastolic blood pressure of less than 90. However, if you have a previous heart attack or diabetic, we aim for a little bit lower because we want it to be even lower. So we aim for 130 on 80. So 140 and 90 is the baseline for literally everyone, 130 on 80 for people who are high risk. So that's what we do. Well, affect kidney function. The good thing about blood pressure is there's probably about 6 or 7 really good tablets in the market, class tablets in the market at the moment. They're actually very good. The side effects are very minimal, and we should be able, majority of patients, we should be able to get your blood pressure down. Obviously, there's some hard ones, but treating blood pressure these days, we're actually pretty good at it. I normally recommend home blood pressure monitoring. The reason why is we see a lot of white coat hypertension. When you come in, your blood pressure shoot up to 170 or 90, and that's not accurate. So I normally just tell you to buy a blood pressure machine and check it at home. And I normally tell patients to do it 2 times a day and just write a logbook and come and show me in a month's time. So at least we know what we're dealing with. Smoking. There is absolutely no doubt this is one of the most important criteria for ischemic heart disease. What most people don't know is when you had a stent in, this is even more important. Smoking itself narrows arteries, but if you put a metal stent in the artery, your nicotine will kill the stent very, very quickly. So if I have a patient who had a stent in 6 months ago, they keep smoking, they don't do very well. They come back quite often in a year or 2 years' time with more angina, and you go back in the stent narrowed down. So patient with stents in, smoking is a no-no anyway, but with a stent in, that's an absolute no-no. They're really, really bad for you. If you have any heart artery problems, they kill arteries. Cholesterol, I'm expecting question about cholesterol because I basically feel a question on statins every day when I see patients these days. I think there's not much doubt that high cholesterol is associated with a higher risk of blocked arteries. I don't think there's any doubts about that. Purely from a medical perspective, statins, which is your Lipitor, your Crestor, your Zocor, there's quite a few tablets in the market at the moment, They came out, I think it's in late 90s, and there is no doubt that they changed the management of cholesterol completely. They are the most effective, the least side effects, even though you got TV ads about side effects every day. Medication that we have. And it is the tablet that in multiple clinical trials shows that it has reduced the rate of heart attacks. We do think, a lot of cardiologists, myself included, do think that the statins, on top of reducing cholesterol, what it also does is it also stabilize the plaque. So what do I mean by stabilize the plaque is, if you remember what I tell you about acute heart attack, quite often we're talking about 40–50% blockage. They rupture, they clot up, and they clot up the whole artery. I personally believe the cholesterol tablet statins, they stabilize these plaques to make it less likely to rupture. That is a little bit hard to prove, but I think a lot of us do believe in that. And therefore, if you, let's say, have a CT coronary angiogram or angiogram before, we find a 30–40% blockage in the artery, I'm sure 9 out of 10 cardiologists will put you on a cholesterol tablet, will put you on a Lipitor Crestor. That's the reason why. We want to stabilize the plaque. We think the tablet itself will stabilize the plaque in order to reduce rupturing and reduce acute heart attack. Side effects. This been on TV literally, I think, last 3 or 4 months. The main side effect for statins been proven are muscle aches. So a lot of patients get shoulder pain, hip pain, muscle pain. And they tend to get it very badly. It happens very rarely. It's probably less than 5%. But when you get it, it is actually quite painful. There's a very, very small risk of an elevated liver function test. There are multiple, well, myths and not myths. The main concern for your population has always been on TV. They talk about statins causing dementia, which is the main worry. And literally every second patient come and ask me that. If you purely look at the FDA release, which is the Department of Food and Drug from the US, they only talk about statins causing a very, very tiny number of transient memory loss, goes away after you stop the tablets. Dementia has, from my point of view, has never really been proven. Statins tend to increase what we call HbA1c level, which is how we measure the blood sugar level, a little bit, according to one of the major clinical trials. That is probably true. However, I think the increase we're talking about is very small. Looking at all the other benefits from statin point of view in preventing heart attack, there's not much doubt. If you got a heart problem, you should be on it. That's my opinion. What it does is basically, I don't think we should put in water. But if you've got problems, if you've got blocked artery, from my point of view, this is a no-brainer. So what kind of cholesterol level we're looking at? There are different people talk about different things, and some patients think 5.6 is great, some patients say 3.5. What are we talking about? The main thing about cholesterol level you need to understand is cholesterol is not a bad thing. You need cholesterol to be alive. Cholesterol is one of the main components of cell wall. So there's not what we call an arbitrary normal level for cholesterol. What we do know is basically in some high-risk patients, we basically draw up some level guidelines. So if you're high risk, we tend to push it lower. If you're low risk, we tend to leave it a little bit higher. So what I mean by high risk are basically patients for like diabetes or previous heart attack, or we know known blocked arteries in the heart. We aim for a total cholesterol level of less than 4, and LDL level of less than 2. In patients with not that many risk factors, quite often I relax the level to LDL less than 2.6, in a total cholesterol level of somewhere about 5.5. So it depends on where you are sitting. We aim for a particular level. Obviously, you need to understand these levels are arbitrary. So we basically put a line somewhere and say these are the levels. But these are the evidence we got, and these are the guidelines we use these days. So the next lot, do you have time? Or
yeah, sure.
We keep going?
Yeah, we've got 5 minutes.
5 minutes? Okay. I'll run quickly through about what we can do in order to look for heart health. The newest investigation that you might be interested in, we got a whole heap of new things in cardiology, but it's what we call a coronary artery calcium scan plus a CT coronary angiogram. Have anyone heard of it? I assume quite a few heard of it. So historically, to do an angiogram means looking at arteries in the heart. Because the heart artery is very small, as you can imagine, and also the heart is a moving structure, if you want to look at the artery itself, you always need an invasive procedure, which is an angiogram. You stick a plastic tube into the artery, actually shoot the contrast in directly. But not surprising, with technology getting better and better, we actually developed a CT scanner which is good enough to shoot the arteries from the outside. So rather than start sticking things through the groin or wrist, we can shoot it from the outside. And that's the CT scanner we're talking about. I think it costs about $1 million or 1.5 million to do. There is government rebate started last year, where in patients with symptoms, they consider for an angiogram, they get full Medicare rebate. It is not as good as an angiogram, which is not surprising. It is still, the arteries is still very small. And if you look at the distal coronary artery, as you can imagine, the artery gets smaller and smaller the further down you go. It gets a little bit too small to be too accurate. That's the limitations of it. But the attraction is obviously it's a non-invasive procedure. You rip in, you shoot some contrast, you go for a scanner, 10 minutes, and you go out and go home, rather than you stay in hospital having a hole in the groin.
Excuse me, can I ask a question?
Yeah, sure.
Apparently, as you said, from July 2011,
Yep.
there has been government
Rebate.
encouraged rebate. Now, is there any criteria for this?
Need a cardiologist referral.
So you'd have to have be risk factors involved, right?
You can't just, by definition, you can't just walk in and go,
Saying,
I'm perfectly fine. Can I get a scan? You can.
So-
You need to pay yourself.
So it has to be. Now, also, I'd like your opinion. What about a bloke who's in his early 50s
Yep.
and who's overweight,
Yep.
who's has hypertension and high cholesterol, who is on medication for both of those?
Yep.
What are the risk factors if somebody like that? I have to be personal here, so I'm talking about my son. Right, and he's overweight. He's not gross. I mean, you're not going to turn around and look at him in the street.
Yep.
But he is overweight. He eats too much rubbish.
Yep.
Right, but he's on these drugs. What is the risk factor in him suddenly acquiring a treadmill and suddenly? And he's very sporty sort of a bloke, despite the fact that he's overweight. What is the risk factors in him suddenly starting quite vigorous exercise?
Low. I think the answer is low. Unfortunately, to give you an accurate number is impossible because everyone is different. But in someone like your son, who is a little bit obese, who is overweight, who have high cholesterol, high blood pressure, the one thing we do suggest is basically to try to lose weight and exercise. So I will have no hesitation in supporting to get a treadmill and try to get moving at home. Regarding what's the risk of having a heart attack on a treadmill, to be honest, we can't give you any accurate number in these things.
That's not a bad idea.
No, I think it's a great idea. I think if you look at my whole talk, the one thing that I emphasize on is actually lifestyle. We can't give you tablets, that's no doubt. But on top of the tablets, you actually need to do your own. You need to do your own job too. And in order to try to lose weight, that itself is actually a risk factor in order to reduce heart attack. So I think it's a great idea. I would probably, if I were you, I'll pay for the treadmill and actually try to get them on it every day. That's what I would do.
Come back. It is, yeah. You're getting some exercise on me.
Dr. Wong, are DVTs an indicator that are used for heart problems later on?
No, DVT is something completely different. So DVT is deep venous thrombosis. I'm sure you read it somewhere when you go on a plane. They normally talk about it. So DVT, what happens in DVT is when the blood in the legs pull in the veins. And what happens is if you, normally when you walk around, the muscle pump the blood back into the heart. If you for some reasons, you don't move around, for example, you're stuck in a plane to London for 24 hours, or for example, you had a hip replacement and stuck in bed for a whole week because you can't move, then as you can imagine, the muscles stop pumping the blood from the veins back to the heart. The blood becomes stale, they don't move, and you can imagine, just like you cut yourself, when the blood don't move, they clot. So what happens in DVT is, in this situation, then the blood clot in the legs, and it causes what we call deep venous thrombosis. It is potentially dangerous because the clot itself can dislodge and can go to the lungs. And in some patients who had a hole in the heart, it can go through the hole and go onto the other side and cause a stroke. If the clot is big enough, it's potentially lethal. All right? So if you've got a huge clot, dislodged, stuck in the lung, block off all the artery, you can drop dead from it. Therefore, we are a lot better in treating DVT. For example, you go on an airplane, they talk about getting up and moving around every 2 or 3 hours. You go and have a hip replacement next door or any hospital, we give you Clexane injections to thin the blood. That's the reason why. But purely from the heart, ischemic heart disease point of view, well, not unfortunately, the whole pathology is different. This one is secondary to venous blood not moving, causing clot formation. In a heart attack situation, we're talking about a blocked arterial artery. So it's actually 2 different things, and the risk factors are different.
I have a second question, unrelated. Yep. In these CT angiograms, yep, when they draw this pretty picture of your heart with all these little veins, and they say to you, okay, from what we can see, you don't have any risk factors there and you shouldn't for the next 4 or 5 years.
Yep.
How reliable is that?
Pretty good, actually. Pretty good. Unfortunately, to give you always a quantified risk has always been very difficult in these things. But if your CT scan showed a completely normal arteries, then that is as good as a normal angiogram. As a matter of fact, I will argue, I think a lot of my colleagues would disagree with me, purely from screening point of view, a CT coronary angiogram might be even better than a normal angiogram. The reason why is because it's a technical thing. A normal angiogram, you should contrast into an artery, all right? The plastic tube goes all the way into an artery. You should contrast down the artery. All you can see is the lumen of the artery. You can't see the wall. You can't see the outside. All you see is just black tubes. A CT scan, what it does is basically on top of the tube itself, you also see the wall. You can also see calcium. You can see a little bit more. So it gives you some different information. Let's assume you go and have a CT coronary angiogram done, and you have no calcium in the wall, so your calcium score is 0. There's no plaques you can see, and you can pretty much call that normal artery. And I think that is actually very accurate.
Mm. One final question, how reliable are these stress tests then?
No, not very reliable. So there are different types of stress tests. All right, there are what we call simple stress tests, which is just run on the treadmill. There is what we call a stress echocardiogram, where you run on the treadmill and we do an echocardiogram before and afterwards. There's also what we call myocardial perfusion scan that's done in nuclear medicine, where there's a little bit of radiation. You also run on a treadmill, they give you some medication, and they screen your heart with some x-rays. I think I'm in trouble after this. Purely from a simple stress test
back you up.
View, sure. Purely from a simple stress test point of view, I don't think it's very accurate. If you look at the data, it's about what we call 70% sensitivity, which means it picked up 70% of the abnormalities, and 70% specificity, which is 70% where you know what you're looking at. Stress echocardiogram and myocardial perfusion scan, on the other hand, the number go up to 85 to 90%. So I don't really believe in a normal, just a simple stress test. I do believe in a stress echocardiogram and a myocardial perfusion scan. It is a difficult question regarding which one to use, regarding with all the CT happening and all the stress testing happening. It is a long talk to professionals to GPs. Unfortunately, probably beyond the scope of this. But I do believe stress testing definitely has its role, continue to have its role in the future of cardiology. There are more sophisticated stress testing available, and I think it will stay that way for the foreseeable future.
In a patient that's apparently considered at some risk by his cardiologist, that is me, and because he has me on Cardizem and that form of aspirin known as Astrix with the pellets in a capsule. So far as I think the only symptom that I sometimes suffer is breathlessness on exertion, and I wonder what is that significant?
Have you ever had an angiogram done?
Yes, I have. I've had
what did they show?
2 angiograms done, and they've not shown any bad blockage at all.
Did they show any plaques?
Any? I think a little, but...
Okay, so the angiogram is the gold standard from our point of view.
Pravastatin.
So the angiogram is the gold standard from our point of view. So that is the be all and end all. When doing angiogram, it's showing no blockage, then that's full stop. There's no blockage. All right. Then the question is going to be, you're short of breath when you exert yourself. Is there another reason for it? Because purely from an artery reason, assuming, because I don't know your history very well, purely from artery reason, there's no reason why you should be short of breath from the artery point of view. Unfortunately, breathlessness is a symptom which is a big area. A whole heap of things can cause breathlessness. Asthma, emphysema, heart failure, valve problem, they can all cause breathlessness. So whether your breathlessness is important enough for us to look into it, I can't really tell you. But if you had 2 normal angiograms, and I assume the angiogram is not that too long ago, then artery is not the cause of your breathlessness.
Is there any relationship between peripheral vascular disease and cardiac problems?
Yep. As I mentioned in my first few slides, if you had a blocked artery somewhere, your chance of having a blocked artery elsewhere increased dramatically. That's just the nature of it. So, for example, if you got a blockage in one of the femoral arteries or the iliac arteries, you are at a high risk of blockage up here.
Two TIA. I've had 2 TIAs as well. So.
Yeah. So you're at a high risk of a blocked artery in the heart. Whether what to do about it, that's a different question. But if you're purely asking the question of what's the risk of me having a blocked artery in the heart, I think you're high risk.
Thank you.
We might let other people ask questions, and then we'll see how we go. Thanks.
Shall we continue, or?
No, keep going.
Okay.
Unless there's someone else. Bruce?
Thank you, Doctor. Actually, 2 questions. You mentioned about killing the stent with the nicotine.
Yeah.
Is that to do with the chemical construction of the stent?
I don't think anyone knows, to be honest. To exactly talk about pathophysiology and these things are quite hard because we can't go into the artery to have a look at what happened. But if you look at the data, and all we can say is the data, there's no doubt smoking actually restenotes the stent a lot quicker than normal. And therefore, if you had a stent in, you should, well, look, even if you're perfectly healthy, you probably should stop smoking anyway. If you've got a blocked artery, if you've got angina, you definitely should stop smoking. If you had a stent in, if you don't smoke, you're silly.
Just following from that, what is the stent made of? Is that
the stents, so I'll give you a bit of history. So initially in 1980s, when we first do angiograms, what we do at that point is basically we feed a balloon down, we blow the balloon up, open up the artery, and then come out. That's been proven to be fairly unsuccessful. What happened is you blow the balloon up, open up the artery might look good for about a few weeks, but because you cause a lot of damage to the what we call endothelium, which is the lining of the artery, it's damaged, so it get restenosed very quickly. So balloon angioplasty basically gone out of fashion. Then in the mid-90s, I think early 90s, mid-90s, we start to develop stents. Stents are usually metal stents, and there are quite a few different ways of making stents. And to be honest, I won't go into it. But they're literally metal stents like a net, where you can deploy into the artery and leave it there forever. All right. Initially, we start with bare metal stents. They are very good. They are much better than just pulling a balloon down, but they seem to have a increase. They seem to have a pretty high risk of also getting narrowed in the future, especially when they're small stents. These are all technical stuff. Then in the, I think in around 2001, we got what we call a drug-eluting stent, where it's still a metal stent, but on top of the metal stent, there's a coating for chemotherapy. And there are multiple types of chemotherapy they put on it. The whole idea is to prevent cell from overgrowing over a stent, therefore reduce the risk of restenosis of the stent. We call them drug-eluting stents. And there's quite many different brands, many different medications, and to be honest, you probably don't need to know much about it. But the DES stent at this moment in time is probably the stent of choice. Obviously, things become complicated when you're getting old and you've got big artery. That's beyond the scope of this talk. There are studies done in the world these days where there's a new type of stent called a bowel prostatic stents and bowel resorbable stents. They are still on clinical trials at the moment. So at this moment in time, they're not available. Whether they will become the future, we'll find out.
Thanks. The other quick question, you mentioned the extra great service for North Shore and Sand areas. Do you have any knowledge city and inner west area, like RPA, for example?
So as I mentioned, there's like 10 cath lab in Sydney at the moment. So there's literally more cath lab than, I don't know. So literally in Sydney, they're very well covered. So the 24-hour service is done literally in every major tertiary hospital. I think RPA, St. Vincent's, Prince of Wales, St. George, you name it, they got it. So literally in the Sydney Basin, the heart attack treatment is fantastic. Once you get out of Sydney, then when you get to Bathurst, Orange, Double, even Gosford, Wollongong and Gosford got a cath lab, but they don't do 24 hours. So once you get off the Sydney Basin, then the service tends to drop a little bit. So it is lucky to live around this area because the service is very good. Unfortunately, our country colleagues and our country friends, their service is not as good. That's the truth.
Thank you. Okay.
Keep going? Yep.
Yep.
CTCA is a new thing. People worry about CTCA because radiation. But to be honest, CTCA, the radiation is actually not that high. You need to take my word for it. 5 millisieverts is hardly anything. I don't recommend you to get screened every year. All right? But I think just one screening, once in a blue moon, is not a bad idea if you do have some risk factor and symptoms. These are just some pictures, CTCA. I'll just quickly run through them. This is an artery, the white stuff. If you can, this is a normal artery. You can see there's a blockage. This is what we call calcium in the artery. You do tend to get calcium build-up when you get old, all right? But calcium also means there's something happening in the endothelium, in the lining of the artery. So when I see a lot of calcium in the artery, I normally tend to treat the risk factors very aggressively. These are more blockage in the arteries, where you can see from CTCA, you can see this black stuff blocking off the whole artery. I call that severe stenosis. So this is what you can see from a CT scan. It is still not as good as an coronary angiogram, but I think it offers an alternative to look. And this is what you see, the 3D ones, where they print a very pretty picture. They usually give you a book to go home with. And if you have it, you have the book. They show a blockage here. And they also, these are stents. As you mentioned, they are metal stents. So metal shines on an X-ray. So you can see this white lining. These are stents. Okay? And you can see the stent got acutely blocked, which is what happened if you had a stent, you would know, your cardiologist would tell you to take aspirin for life. And if you had a drug-eluting stent, they would ask you to take Plavix for 1 year. If you had a bare one, they would take Plavix for 3 months. The reason why is because this can happen. If you don't take your antiplatelet agent after stent implantation, what happens is you have bare metal sitting in blood, and blood don't like metal. and blood will clot up metal any day. Imagine you clot up metal in your artery, that's a heart attack. So it's crucial for patients in general to behave and follow the orders. It is actually very important because we've seen quite a lot of acute block stents because the patient feel perfectly fine, especially young blokes, 35-year-olds. They go, what the heck with this aspirin? They chuck it away after 2 months. They feel perfectly fine. They come in with an acute heart attack. These tablets are not to make you feel better. As a matter of fact, they might make you feel a little bit worse because they can cause some tummy upset and etc. But it is important to look after the stent once we put it in. Problems. CTCA is not the answer for everything, unfortunately. If you have low calcium in the artery, it is not very accurate. So that's why this scan is still reserved for cardiologists to order it, because we tend to know when is a good time, when this scan will show good information, and sometimes this scan will not show good information. All right, so it's not like we should scan everyone. We shouldn't. This should be done in consultation with someone who knows what they're doing. Stress echocardiogram, I sort of mentioned before. Stress echocardiogram is the stress test with an echo before and after. I do think it provides more accuracy. I like it a lot better than a normal stress test. I definitely think there's a role for these things to be done. I actually personally prefer to do this for all my patients rather than a stress test, but a lot depends on what's available and what's not available because you need the equipment for it. But it is more accurate, and I like it. That's all I have.
Well done, Tommy. Very good.
I think I run over time.
All right. Is there one last question?
Yes.
No. Well, I want to. Well, I'll make that decision, but I want to give other people a chance, and then if there isn't anyone, I'll let you have it. One last question. Okay.
I guess I'm one of these at-risk patients because I had a heart attack, a mild heart attack, admittedly, nearly 20 years ago.
Yep.
I've had a number of angiograms.
Yep.
One was an attempt to get a stent in, and they couldn't get it in.
Yep.
With these new advancements that you mentioned in the CTA scans and what have you, you didn't mention any advancement in the ability to get the stent in.
Because I guess it's beyond the scope of this talk. Because this becomes...
Well, has there been any? Is it worth my while going and bashing on my cardiologist's door and saying, listen, have another go, get that stent in?
I think we need to be sensible about these things. I'll go a little bit deeper. These are more talks for fellow colleagues. If you look at the data, stenting, surprisingly, like for example, putting a stent in an artery, do not improve mortality. All right. So simply by putting a stent into an artery, for example, say a 70% blocked artery, will not make you live longer. There's no doubt if you put a stent in to open up a completely blocked artery, your life is completely different. However, when you have a stable artery, the clinical trials do not show a definitive improvement in mortality. That's done about 5 to 6 years ago with old stents. So with the newer stent, it's hard to say what we're looking at. So we always need to judge these things regarding a patient itself, your symptoms, and how big or small the artery is. Quite often, then we ask ourselves, if the artery is very small, it is unlikely to supply a large area of the heart, then trying to take a lot of risk to try to force a stent in, because it's a small artery, is unlikely going to make a large mortality difference. If you're asymptomatic, it is probably not worth it. Okay, so unfortunately, these things, there's no clear-cut answer for you. There are multiple ways where we can try to force stent in. You know, quite often, as a cardiologist ourselves, we ask ourselves, is it worthwhile? All right, it's not like we should put a stent into every single blockage in the artery. Quite often, the blockage is not suitable for stenting. The blockage is in a difficult place, and the blockage is actually not that big. It's not causing problem. A lot of my colleagues will just leave it. So unfortunately, I can't give you a clear-cut answer on every single case, but I hope you get to it. It's not like a blocked artery should always have a stent in. It doesn't go that way. And quite often, if it's a very small artery, to put a very small stent in, you will find the rate of the stent getting narrower is actually quicker than your normal artery. Because stenting-wise, purely from a stenting point of view, the larger the artery, the better the outcome. If you're trying to force to put a small stent in, you know, your normal artery might last for 2 or 3 years, your stent might only last for 6 months. So it's actually doing you a disservice. So I wouldn't suggest you to knock on your cardiologist's door and force him to put a stent in. I think if you're symptomatic, you get chest pain, that's something you can consider. But if you're perfectly fine and your cardiologist decides that artery is too small, too difficult, I will agree with it.
The only other thing I wanted to mention was symptoms.
Yep.
Symptom I had, which took doctors way back then 4 months to diagnose, and it's still not very widely known, is an aching in the base of the jaw,
Yep.
which is, I guess the reason I'm saying this is because I know this is going to go on a DVD. Everybody should know it. Most people don't.
Yep.
It's a typical symptom of heart
So your
problem.
typical symptom for angina, as I mentioned before, your classical textbook symptom is central chest tightness, pressures on the chest, radiate to the left arm and radiate up the neck, and quite often all the way to the jaw. Typical angina symptoms are you get these pains when you walk or when you exert yourself and get better when you stop. So if you get these symptoms and you come and see me, I'll go, I think you got a blocked artery until proven otherwise. You always look. What way you look, that depends on situation. You can do a stress test, you can do a CT, you can go straight to an angiogram. But you know, these depends on the situation. But your typical heart attack, well, angina symptoms, that's what you get. Obviously, as I mentioned before, there are many variety of atypical chest pains, unfortunately for us. So your left-sided chest pain, right-sided chest pain can be angina too. But you know, if you talk about classical, this is what classical means.
Yeah, the only reason I was mentioning it was the only one I had was the jaw.
You can get it.
And I didn't have anything else.
Yep.
And people thought it was a problem with my neck, actually.
No. If you start to come in and see a GP or a cardiologist.
20 years ago.
Yeah, if you walk in and come and see me or any cardiologist, you tell me you got jaw pain when you walk.
Okay.
You were still in school.
I was still in school, yeah. But if you got jaw pain when you walk, we go with angina until proven otherwise. We don't muck around with it.
Now, Tommy, we've got to get you away because but there's one last final question.
Yes,
Ma'am?
I'd just like you to explain the difference between women's heart attack symptoms to men, because they can be totally different.
Well, I don't tend to put a lot of emphasis on gender in symptoms. So I just treat. Unfortunately, when you come in with chest symptoms, with pain somewhere around the precordium, I treat you as a heart attack. I treat you as a heart pain until proven otherwise. Because as I explain to patients, there's a variety of things here can cause pain. The most important one is heart. All right. So the first thing we always do is we want to make sure it's not a heart pain. And if it's a chest wall pain, then a chest wall pain is not going to kill you. If it's a joint pain is not going to kill you. But when you come in to see us, we go, let's look at the heart first, make sure it's not heart, and then we can look at something else. That's what I think all of us practice. And if you go to emergency, that's what they'll do too. Purely from women's point of view, look, I don't think there's a major differentiation between the pain. The symptoms are the same. It's exactly the same thing we look for.
So you're not different, Pam. Okay, well, it's been an excellent session. Thank you very much,
Oh, thank you very much for inviting me.
It was a very good presentation, and you can see by the calibre of the questions and then the answers, it's a very beneficial session for everyone. So I'd like you to help me thank Tommy for coming tonight.
Thank you.